Good morning, good afternoon, good evening. My name is Menoze, and this is my final case presentation for our SOW 6558 Field Instruction course. All right, so for the case overview, our patient is a 26-year-old white female, and she has a presenting problem of generalized anxiety disorder. She was on the referral list for a while within our psychiatry unit. So when I was able to connect with her, this was like her first time being in psychiatry or in therapy in general for a long time. So the patient has had a psychiatric history of major depressive disorder, borderline personality disorder, generalized anxiety disorder, opioid use disorder, and alcohol use disorder. She also has a history of substance abuse, trauma, and trauma due to any domestic and physical abuse that she experienced previously. All right, so here is the engagement and assessment portion. So when I was able to finally connect with this client, we had to do a lot of like brief things only because of the time limits that we had. We had some time constraints, so there was not much things that we could do. So because of this, it was very important that I built rapport very immediately. So I made sure to build rapport immediately through our initial evaluation. We had a limited number of sessions, as I previously said. So it was imperative that I built the trust early, and I built that trust through open-ended questions, active listening, finding common ground. Me and the client are around the same age, so there were some things that I was able to relate with her on. So much so that she came to the point where she said she felt more comfortable speaking with me with any over any other provider that she's experienced. And then just honestly just being authentic, showing up as myself, and then letting her know that I was there to help support her in any way that I can, even though we were going to be together for a short period of time. So here were some potential barriers to progress that I kind of evaluated after our initial evaluation. So personally, the patient initially displayed like a readiness to change. However, she had issues showing up for sessions at the beginning. So there was times where I had to reschedule with her because she just didn't show up, or something popped up and she said she had work even though she made sure to confirm the time with me. So that kind of caused a rift within just our time together because it was already brief. So being that we had to continue to reschedule and all the things, it impacted the way that I was able to provide service and the different treatment opportunities that I wanted to do, or options that I wanted to do with her. And then she also has a history of substance abuse, but she also lacks community support. And these two things were really big because with that history of substance abuse, she kind of alluded early on that she was feeling need, like she wanted the need to go back into the substance of like alcohol. Um, just so she can feel something again. And her not having any real community has caused her just to be by herself, and honestly just will push her to continually doing that substance in secret. So here are some systemic barriers where the patient's highest level of education was a GED. This has limited her options in getting a job that pays well, and this causes financial strain. This financial strain has also showed up in just the way that she's able to support herself. She's very anxious, but also very just stressed out when it comes to supporting herself, living alone. She typically cannot pay rent fully by herself. She has to rely on her mom to help pay for some things. So that was one of the stressors that we also saw kind of contributed to that initial diagnosis of generalized anxiety disorder that she's experiencing. And then organizationally, the patient was on the wait list for a long time due to just the high caseloads within the clinic that I work for or that I intern at. And this may have exacerbated her symptoms even further. So, here's just a comprehensive biopsychosocial that we did with her. So, biologically, she was born in North Carolina and raised in Florida, and she lives in St. Pete currently. There's not much information biologically, only because she was adopted, and she does not have much information on her genetics and all that jazz. But that's her biological. Psychological, she has a history of substance abuse, struggles with self-esteem and emotional regulation. She also just has the history of MDD, BPD, opioid use disorder, and then also alcohol use disorder as well. All those things have impacted how she thinks, how she sees herself, and how she moves through life. Socially, she does not have much of a social life. She currently lives alone. She has a best friend that she speaks to every single day on the phone, but she has not seen them in person in years. But this person lives in Tampa, and resides but our patient resides in St. Pete, and her best friend resides in Tampa. However, they still have yet to see each other, which caused a concern for me. And then also She was previously in rehab, but she does not connect with the rehab support group as much as she should either. So there is a lack of just social connection in general. And then also, she has not reported anything, any spiritual type of belief or anything that she kind of uses to keep on for hope or anything of that nature. So the initial assessment tools used was the GAD-7, and I used the GAD-7 initially and post treatment to measure her levels of anxiety. I wanted to see where she was at, and she was on the moderate side after doing the test, and I that kind of led my practice of like, okay, she's really experiencing some high levels of anxiety at the moment, and that kind of led my practice of wanting to figure out what's going on there, especially with all the other diagnoses that she has, but also like seeing what interventions would be best fit for her specifically. And then some of the safety considerations is that she was recently out of rehab. She still struggles with alcohol/opioid use, and she lives alone and does not have much support. This is a safety concern because anything can happen, especially if she doesn't have anybody to help her if something does happen. That has been seen to be a safety consideration for my practice, my time with her. All right, so intervention and planning. So these are the theoretical frameworks used. I used dialectical behavior therapy, also known as DBT. So I primarily use this because it's primarily used as an intervention for people diagnosed with borderline personality disorder. And it really does a good job at like also contributing to like helping with their anxiety as well because it focuses on mindfulness, distress tolerance, and things that she honestly just needed, like emotional regulation and all those things. So we really focused heavily on that. We also did brief cognitive CBT, which, and it was brief because there was only a few sessions that we were able to have. But then also CBT has been proven as a good intervention for generalized anxiety disorder. And then lastly, we did the acceptance and commitment therapy, also known as ACT. This intervention teaches the patient to accept their thoughts without judgment and commit to her actions. So she has a lot of goals of wanting to do better and all the things, but she tends to feel bad about herself and have low self-esteem due to all the things that she's experienced and the health and the substance abuse and all this stuff. So we want to target that, but we also wanted to target like, okay, if you say you're not going to do this again, let's make sure we're committing to the actions that we have in place for ourselves. But mainly just in general with my practice with her and our intervention with her, it's my focus was on ensuring her safety because I know she already struggles with something like this, but also encouraging her self-determination, empowerment, and then also collaboration. So she was within this intervention planning, it was really her kind of leading like what she wants to do, and we just collaborated on it, and then we went from there. Alrighty, so now we're on our evaluation and termination. So for the evaluation part of things, I made sure to still do the GAD-7 to measure anxiety levels post-treatment just to see where she would be at. She was still moderately to high levels of anxiety due to one, how brief the sessions were, so there was not much time to continue to get into all of that, but then also just like all the things she was experiencing, she did unfortunately have a relapse to her alcohol abuse or her alcohol use during, well, prior to sessions that she disclosed to me a little bit later in sessions. So that kind of dictated also where she was going through. But also with the evaluation, I make sure to connect with my supervisor consistently regarding this case because this was very new for me specifically, and just really leaned on her feedback to guide me in practice and just for recommendations. She was the person, my supervisor was the person to recommend that I specifically use DBT for her because she has borderline personality disorder, and that has proven to be very helpful, at least with the time that we did have. I also, for our termination, I make sure to have the patient reconnect with her rehab support group. I encourage her to do that just so she has that support, and also just like when she is experiencing this alcohol use again, she has somebody to talk to, and they can guide her through the process and make her feel like less alone because that support is very important. Also refer the patient for continued support to the therapist within my office. So my supervisor is also a therapist, and she is willing and open on taking on the client after I leave and after I complete sessions with her and actually after we terminate. So the client will continue to have that support because even from the beginning, when I started meeting with the client, I already saw that she was going to need some extra support post our time together. And then also just making sure we did some safety planning to make sure like, hey, if she is going through this stuff, does she have people to call? Who does she call? What are some triggers for her? What are some ways that she can cope more effectively and less harmful? And then also we just reviewed any interventions used during our sessions, which was a lot of just distress tolerance, emotional regulation, and mindfulness, because that has proven to be beneficial for her in the past. How the CSWE competencies have like been integrated within this course. So, for our ethical and professional behavior, I let the patient utilize her self-determination and treatment planning. So, she was heavily involved in what she wanted to focus on, but also just her self-determination and her choices, especially when she did um, relapse and started taking not taking but drinking alcohol again. Kind of gave her like, hey, these are some options that we could do, but also like, if you go down this path, this is how that might look. If you go down this path, this is how might that look, and gave her the opportunity to do it, because at this point it's like up to her and her self-determination. But she did decide to go back to her rehab groups, which I was very proud of her to do that. So I just supported her in whatever area she decided. um, I I I showed human rights and justice by providing resources with the job support. Because she has a GED, there's limited job support that she can get. So I wanted to provide her a resource on that, of like where else to look, so she can potentially get some higher income, so that's less stress on her. For competency three, I treated the patient with dignity and respect, um, to just to make sure that she was seen as a person, because that's who she's supposed to be seen as, because she is a person. For competency four, I implemented DBT and CBT evidence-based practices, just to ensure that we were staying consistent with the research-informed practice that we know of. For five, I connected with my supervisor to ensure that there are any additional resources in the clinic to provide the client. I really wanted to make sure that I was doing my due diligence to support her, especially when when she did fall back into alcohol use. So I wanted to make sure that, is there anything within our client and within our clinic that we can do to help support this client? And I was able to connect with my supervisor and provide those resources to my client. Um, Number six, I made sure to build rapport with the client and reflected on her choices, regardless of what it was, regardless if she felt like she may be judged. I made sure it was an open and just safe space for her, so much so that she felt open to confide in me and all the things. So I thought we did a really good job there, just building rapport and just making sure that she felt safe and comfortable. With the assessment of our clients, I made sure to administer the GAD-7 to assess anxiety levels pre and post test, pre and post interventions. Number eight, I made sure to administer DBT to be culturally competent regarding her current diagnosis, which is BPD. And then also made sure to assess GAD-7 and evaluate it, if DBT was actually effective for her, based on her feedback. And she did. So based on her feedback, she said the mindfulness specifically has been proven to be beneficial for her. So here is some professional self reflection that I had. This case taught me the importance of being flexible as a clinician. I think it's important to have the foundations of intervention in theory, but once I unearthed like what was everything that was going on with this specific client, I found that presence was a little bit more impactful than any of the interventions I could give her. This was like the first time the client felt comfortable confiding in a therapist or confiding in into a mental health professional or whatever the case may be, where she was able to confess like, hey, I'm still struggling with this. And a lot of times I would arrive in session ready to have things to talk about and interventions to do, but sometimes we just had to sit and I just had to talk. We just had to sit and I had to be present, talk her through it, give her and just like give her the space to be human and all the things. So I found that this specific case showed me how important it is to have that, and obviously keeping those foundational things in place. But that presence of a social worker, that presence of a therapist, of a clinician, whatever the case may be, is so important and can have so much more breakthrough than we may realize. So lessons learned is to be more present, collaborate with the client on treatment planning, always, 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 always. That has been proven to be just very beneficial. And then it just showed that she was still like intentional and like continuing to do what she needs to do. Some areas for growth for me would be to get more training on substance abuse interventions. This was my first time dealing with somebody that had such substance abuse like for such a long period of time. So I wanted to ensure, I did some research and stuff like that prior, but I want to just get a little bit more, instead of being so general, a little bit more specific on substance abuse interventions, and like see what type of training I can get in order to help anybody that I might encounter in the future. And then just for some professional self-care, continue to discuss cases with during supervision. That was has proven to be very beneficial for me, because it allowed me to get a better understanding, but also like get off any biases or any like stress or just like um anything that I feel like I needed to speak on. I was able to speak in confidence to my supervisor and then get really good feedback and then like resources on how I could best and effectively help this client. Another professional self-care for me is exercise. I need to get those endorphins in. Also reflective journaling, separating. That means like separating myself and just like realizing yes, I can be a clinician, but I'm also a person, so trying to separate the work, even though that's hard because I do care about these clients, but in order for me to be just a better clinician in general for myself, I think separating myself would be helpful at the end of the day, and then also just spending time with friends and family, which is kind of ties in with separating myself. And here are my references. Thank you so much for the opportunity to discuss this case, and I hope you have a wonderful day. Bye bye.